Latarjet operation was first described by French surgeon Dr. Michael Latarjet and has been used very successfully to reconstruct shoulders with recurrent anterior instability. The modern version of the original technique prevents further episodes of dislocation in 98 to 99% of patients and has a very low complication rate. The operation is ideally suited for contact athletes, patients with increased shoulder laxity, failed previous shoulder reconstructions, and if there is significant bone damage as well. A deltoid pectoral approach is used to expose the coracoid process. The coracoacromial ligament and the pectoralis minor attachment are divided, whereas the coracobrachialis and the short head of the biceps origins remain intact. The coracoid is osteotomized at its knee, yielding bone graft approximately 1.5 centimeters in length. Great care is taken to avoid damage to the soft tissues and musculaneous nerve in the surrounding area. With the arm in external rotation, the subscapularis muscles either split along its length or detached from the lesser tuberosity and joint is exposed. The graft is shaped and contoured to fill the defect and is secured with a screw fixation placed at the anterior-inferior glenoid. With the coracobrachialis and biceps still attached to the coracoid, they now serve as a dynamic sling, further stabilizing the glenoid-humeral joint. Subscapularis split is then repaired.
You can begin range of motion with flexion by passively moving the patient into the position slowly without causing pain. Continue passive range of motion with internal and external rotation, with the shoulder abducted to 30 degrees. Limit internal rotation to 45 degrees and external rotation to 25. Codman's pendulum is a good beginning exercise when starting range of motion. Have the patient lie prone with the injured arm hanging off and instruct them to slowly move it in a small circle. You can advance it by adding weight or adding gravity in the supine position. During phase 1, you can begin isometric strengthening in forward flexion, extension, and abduction, while avoiding internal and external rotation at this time. In this phase, you can also have the patient perform light forearm exercises such as a therapeutic squeeze progression for grip strength.
To assist the progression onto active assisted range of motion and active range of motion, you can use joint mobs for the glenohumeral joint in the plane where range of motion is restricted. One good tool to facilitate active assisted range of motion is the pulley. Patient can be seated or standing, using their non-injured arm to raise the injured arm through the range of motion. We also use the T-bar as a tool to assist in active assisted range of motion in forward flexion and in abduction. We use PNF patterns D1 and D2 to help the patient regain their active range of motion. We use these patterns because they are similar to the motions required in most daily activities and sports. We then incorporated rhythmic stabilization to achieve stability and neuromuscular control within the joint. Near the end of Phase 2 of a Latarjet rehab protocol, you are able to begin lightweight, high-repetition strengthening exercises. For this, we did the IYT exercise, where the patient raises light weights out in the IY and T formation. In Phase 2, we incorporated the upper body ergometer to continue building the patient's range of motion, strength, as well as keeping up their cardio.
In Phase 3, we included strengthening exercises for internal and external rotation, starting with isometric holds and moving on to TheraBand work. After TheraBand, we moved to light dumbbell with the patient lying on the table in the supine position. We also included TheraBand work for abduction, forward flexion, and extension. Near the end of the phase, we advanced further biceps, scapular, and pectoral muscle strengthening. As you can see here, we advanced through the push-up as he's on his knees to off his knees. We then also incorporated proprioceptive and neuromuscular control exercises.
In Phase 4, we progressed to more strenuous proprioceptive and neuromuscular exercises with an added strength component to them. The first one we did was a planked medicine ball roll. We then added a push-up component to the planked medicine ball roll. We then ended with an agility ladder exercise progression for the upper extremity. Next, we intensified the strengthening exercises by adding more weight. These exercises included dumbbell bicep curls, lat pull downs, dumbbell flies, dumbbell overhead press, and bench press.
The final step in a rehab process is to move on to sport-specific functional progression to get the athlete back to playing football. We want the player to be adequately stretched and warmed up prior to throwing. Gradually advance the athlete through a throwing progression, beginning with short distance throws and slowly increasing the distance and number of throws on a day-to-day basis. Then progress the athlete to throwing on the run, going to his left and right side, and doing shovel passes and handoffs as well.